So welcome everyone to today's webinar. My name is Erica Carnevale. I'm the head of marketing communications at Volpara Health. And with the research showing that there's potential for up to 80,000 delayed or missed cancer diagnosis in the US this year due to COVID, Volpara really wanted to kind of rally our great partners to offer and share best practices among screening programs to help during this time. So today we have a really great session for you. We thank Dr. Keller so much for coming and sharing a little bit about what Lake Medical Imaging's personal screening program looks like. But also want to thank Ambry Genetics, who also contributed to today's webinar. And then on the line, I also have Allison Hansen, who's an expert in the Volpara breast health platform. And so I think we've brought together some really great expertise for today's discussion. And we feel fortunate for everyone that's joined us on the line today. Before we jump into the webinar content, just a brief reminder. These are two buttons that we've become very familiar with during quarantine and virtual work. I did just want to ask, if you haven't already, if you're not presenting, please turn off your camera. I did mute everyone but today's presenters. However, we will have a live Q&A towards the end of the session, where you'll be able to unmute yourself and ask questions, or you can send them in the messaging chat here. But just a good reminder to be a little due diligent about these two important buttons for today's discussion. During the webinar today, we're going to be covering a variety of topics, but fortunately, we're not going to be following the death by PowerPoint format. So Allison Hansen, again, Volpara's breast health platform expert, is going to lead us through the discussion with Dr. Keller with some pointed questions. It'll be much more of a dialogue than maybe some of the webinars you're used to. And we so appreciate both Dr. Keller and Allison facilitating that approach. It should be a very good discussion. You may have noticed when you joined, we did go ahead and record this session. We had a number of people who were unable to attend, so we will be making this recording available to people after the session. That includes today's attendees. You'll get an email with a link to the webinar, so you can replay and revisit or share with your colleagues as well. So with those brief comments, I'm going to hand it over to Allison, and we can jump into Lake Medical's story.
Great. Thank you, Erica. Lake Medical Imaging is based in Central Florida with 6 convenient full-service imaging centers in the Villages and Leesburg. They perform over 52,000 mammograms annually. And in 2018, they were recognized for having the best breast cancer detection rate in the southeastern US. Dr. Catherine Keller is here with us. She's president and managing physician. Hi, Dr. Keller.
Hi, welcome everyone.
Would you like to introduce yourself to our audience?
Sure. I've been here at Lake Medical Imaging since July of 1988, my first real job after fellowship. And here I am after being the 5th person in the group when I joined. Now we are a group of 24 and I'm the president. We have, as Allison already said, 6 imaging centers that are full service, and we're the main outpatient imaging group in the area. All of our radiologists are fellowship subspecialty trained, and we pride ourselves on having a very patient-centric approach.
Well, to begin, could you tell us about your local population? What's unique about your patients?
Well, our patient population is different from many because about 75 or 80% of the women are Medicare age, which is 65 or older. So what that means is that, first of all, they expect a very high level of customer service and personalization. Because of their age group, their breast density is different from a more widespread age population. It's about 25 or 30% of them have the C and D density, whereas in the general population of women over 40, it's more like 40 or 50%. Another thing that makes it different, but is a good thing, is that because of their age group, many more of them have had a mammogram already, and so I can find prior mammograms. We try to get them ahead of their first appointment, and if not, we get them within a couple weeks. But when you have prior mammograms, you can really decrease your recall rate, and there have been papers that show that. So that's a big help to us. Our average recall rate is about 6 to 8%, so that's quite good.
Nice.
Yeah.
Thanks for sharing that. So you do a large volume of screening and diagnostic exams, as we have already outlined. What's your referral base like?
Probably similar to other places. It's mostly primary care physicians, OB/GYN doctors, surgeons, and oncologists. So that's pretty average. And then because a woman can self-refer for screening, we do get a number of women who are just self-referred.
And how do you differentiate yourself in your marketplace?
So there's a lot of competition for women's imaging. Since the designations were first developed, we've been a breast cancer imaging center of excellence and a diagnostic imaging center of excellence. So that's an important name recognition. But the most important thing we do is to try to be patient focused and give personalized and compassionate care. So what we did is that for every patient who wants it, they can get same-day results on their screening mammogram. That's really crucial because so many women are really anxious and fearful about having a mammogram and having a breast cancer diagnosis. The other thing is that we give the ability to have same-day workup. So if you come for a screening, but the radiologist, because we screen and read live, if I see that this lady needs to have extra views or ultrasound, we do it right then. And that way, by the time they leave, they have their answer. Either they're fine, or they have an appointment for some other kind of adjunctive imaging, or they have an appointment for a biopsy. And that really cuts down on the time between diagnosis of an abnormality on the mammogram and your final pathology diagnosis. Usually we can do the biopsy within 5 business days. And we have a lot of different modalities for evaluating women, which we're going to talk about later.
Great. The women in your area are very lucky to have you. I've always admired how progressive Lake Medical Imaging is, and how you're always on the cutting edge of adapting new technologies. Some of them that have forever changed breast cancer detection. Can you walk us through your current technology strategy?
Well, sure. You know, the main idea is that we want to find as many breast cancers as possible, because since there's no magic bullet for what to do to prevent breast cancer, the only thing you can do is have early detection as the best protection. So our goal is to have high quality, consistent imaging and have all the modalities available as possible. Because we're a private practice and not a hospital group, we've been able to do things. We had 2D mammography with the film screen, the special processing back when that was the thing. And then when 3D digital breast tomosynthesis came along, we had that. But even before DBT, we were using contrast enhanced mammography, which we started in 2013. We started doing MR actually in 2003. We were early adopters. So between the breast MR and the contrast enhanced mammo, we were really doing quite a lot, and also with handheld ultrasound. So later on, we got into the DBT and the automated breast ultrasound. With all those things, we really had a lot to offer to help find breast cancer, but we wanted to do more, and that's how we ended up getting involved with the automated breast density and the Volpara enterprise. And then the last thing was with the genetics program.
How large is your staff of technologists?
Well, we have the 6 imaging centers, and we have a total of 43 mammographers. And we have about 10 reading radiologists. So with that many, it's a lot to take care of consistent quality.
Absolutely. 6 sites can be very challenging.
Yeah.
So what tools do you use and do your techs use to maintain and monitor good mammo quality?
Yeah. So initially, all we had was, the reports of the lead interpreting physician and some of the other radiologists and patient comments, but we knew that really wasn't enough. And when I got involved with Volpara's automated density, and then they came along with the enterprise program, that's what really helped, because that lets you look at every single mammogram for proper positioning based on the equip idea of the perfect, good, moderate, inadequate, and looks at the compression. Well, I can tell you that with 6 sites and 43 mammographers and 10 radiologists, it was a nightmare to try to satisfy the MQSA equip rules by hand. And getting something automated to do it was much, much better, more consistent, easier, time saving, and the techs, who I was afraid wouldn't like to be rated, they actually embraced it because it was objective to them. It's not, well, Dr. Keller doesn't like me and that's why she's saying my positioning's no good, or anything like that. It's really very objective and consistent.
Beautiful. How do you use Volpara as a managing physician?
So I really like it because of the dashboards. You get this comprehensive evaluation of all the sites with a quality score that combines both positioning and the compression, and then it's broken down between those things. And then I can really dive deeply and look at each individual site and each individual technologist. So what it helps to do is to make clear where there are needs for improvement, and what areas need to be improved. So like with positioning, you might find that it's always, they're not getting the nipple in profile, or it's always this tech has trouble with the inframammary fold or something like that. It's really quite specific, so you know exactly what to work on. The other thing is that it's a huge time saver to have all that data available when you have to pick out your images for the ACR accreditation and reaccreditation, or if you have to prepare for an inspection. Far more time efficient than how we used to do it.
Mm-hmm. Mm-hmm. And do you go into enterprise yourself and analyze this information, or do you have your techs do it for you, or how does that work?
I think probably different lead interpreting physicians do it in a different way. Because of my time constraints, I have the lead technologist work with me and present the information. Every mammographer tech checks weekly. There's a monthly report for the entire enterprise and broken down by site that's posted so all the mammographers can see, and it gives them a little healthy competition with one another. And then the technologist we have, who is the most proficient with positioning and compression, she goes around to a different site every 3 or 4 weeks and helps them individually work on whatever they need to improve. And that's been very useful too.
Nice, a train the trainer sort of setup.
Yeah.
It's fun for them too. It gives them a new role. What have you said? What would you say? What was that?
I was just going to say that it has been very well received by the technologists, been a tremendous improvement in their quality since we've had it.
Great. What do you think has been the most useful insight that the software has given you?
So I think having more consistent and better positioning and compression I didn't appreciate how much that would help interpretation by the radiologists. There are things that you might think are abnormalities, but the breast position's a little different or the compression's a little different, so you're just not sure. When everything is more consistent, it allows you to read more quickly and have fewer false positives. So that's very important, because the false positives it churns the anxiety of the patient. It makes extra work. You have to call somebody back, do more views, ultrasound, whatever. So if you can be sure it's positive or you can be sure it's negative, that's a big help.
And how about the equipment utilization information, exam times, and some of the referral physician information? How has that helped you as you evolved your personalized screening?
Yeah, so the enterprise system also lets you monitor room use, by technologist, by site, by actual machine, so you can see if maybe one person takes longer than another and help them to be more efficient. As far as with referring physicians, you're able to look at the patient population for a particular physician and see if potentially they have patients with a breast density that need to be having more adjunctive screening, so that then I can target them for education and their patients. So those have been useful.
And you have a marketing team, of course, that helps you with that.
Oh, absolutely. So I help them, the marketers, to know this information, then they go out. But I've also spent a lot of time one-on-one with the referring physicians, meeting them pre-COVID at lunchtime, things like that. And that's really helpful.
Great. Well, given that each state has handled COVID-19 differently, can you share what impact the virus has had on your practice?
Well, it was terrible in the beginning, probably like for everybody. We stopped all our screening, and then we were only doing diagnostics. And then in May, we tried to gear back up to our normal volume. And now we're back to a full volume of about 250 patients a day. Since I'm the president of the group, it was my responsibility to monitor all the information in the medical literature and what the CDC was saying, so that I could develop policies to safely see patients and keep my staff safe. One of the most important things for me is that because we were able to get a PPP loan, I didn't have to lay off any of my full-time techs anywhere across the enterprise. And we have 250 employees total. So I was very happy to do that. Another thing is that because mammographers are in such close proximity with the patient, and they are doing that for that 15-minute key period of time, we had to find a way to keep them safe. So we have all the mammo techs and the ultrasound techs, because they likewise are in close proximity to a patient for the 15 minutes or longer. They were the N95 masks. And when the N95s were in short supply, we had them cover it with a cloth or a disposable mask so that they could get more time out of it. And then we did all the same things that everybody else did, which had to do with, we had to reschedule all those screeners. When patients came, we had to screen them with temperature and, medical COVID questions. Only the patient can be in the waiting room, no friend or relative. No more than 10 people in the waiting room, social distancing, hand washing, cleaning surfaces, all those things that everybody else now clearly knows to do and we're all familiar with.
Well, with the current rise in cases, are you applying any lessons learned or new approaches?
Yeah, well, we're certainly keeping up all those pillars of safety with the social distancing, masks, hand hygiene, and cleaning. The other thing is that we've moved more things to be online so that the registration process is faster and with less contact. There are different forms we have the patients fill out online. Times that they would have been sitting in the office to, for example, see a video that explains a biopsy, we've found a way with our patient portal to link the video so that they can do things from home, and that shortens the amount of time they're in the office and exposed to the outside environment. I think that's just a good best practice.
Technology has really come in handy.
It sure has.
In life, yes. So what we're looking at now is a screenshot from your Volpara dashboard, and it shows your volume and overall quality score. It shows you've had a 15% increase in volume compared with the same period last year, while maintaining a very high positioning and compression quality. How is your team making sure quality remains high?
Yeah, that's really been something, because when you're stressed about fitting in patients that were waiting for months for their screening exam and are extra anxious, and you have to take extra time to clean the machine and keep yourself safe as the mammographer, that's an added stress. So we've really relied upon the Volpara enterprise data to help all the techs see what's going on in the manner that I mentioned before, especially with the monthly posting, and having Megan, that one tech, she goes around and helps one-on-one anyone that has a trouble spot. And that's been very, very useful. As I mentioned, the techs like the objective nature of this evaluation. There are short videos about positioning that are built into it so they can watch to get a refresher. And we used the Mammo Educators group last year to run a boot camp for the technologists, and we can get refreshers from that too. So all those things have been very useful.
Great. This is another view from your Volpara software. In just one click, you can review productivity data that's broken into screening versus diagnostics for one of your sites. How is this data useful to you?
Yeah, so the screenings versus diagnostics is important because the diagnostics take more time for the technologist, and we have to coordinate with having ultrasound, and the radiologist needs more time often to review lots of things. So knowing how you're broken down between screeners and diagnostics, that's useful. And with seeing how our volume increased, we had to make some adjustments in the schedule. Having an increase in the patients altogether while we're trying to socially distance and keep everyone safe has been its own hurdle, but we just did things differently to absorb. We had to spread out the appointment times so that there weren't too many people in the office at once. We increased our hours a little earlier in the morning and later in the evening. We had to add many Saturday days of screening, and some days with diagnostics, Saturdays where you had a radiologist on site. So that's what we did to accommodate it, because if you can't accommodate the volume of patients that you need to see, then besides that it's no good for the patient and referring doctor, you open yourself up to losing the patients to a competitor. They'll only wait so long to be taken care of.
Now let's move on to personalized screening. Let's get more into depth about how you approach your personalized screening. Why was density a logical first step in personalizing care for your patients?
So density was clearly a problem forever with mammography, where more dense breast tissue just made it hard to see the cancer. You know, it has a masking and it's hiding. And we know that most breast cancers are in women with C and D density breasts. So as we were using the Centibrite, making the best recommendations, that's the contrast enhanced mammography that we started in 2013, we made those recommendations based on density predominantly. And so we needed to have a consistent, reproducible way to be assessing the density. And by doing that with an automated manner, then it could be consistent year to year and between radiologists, giving the patients confidence in the read and the referring doctors a great deal of confidence in what we were doing. So that's what got us involved in density. And as far as having the automated density, we wanted to have consistent, reproducible recommendations for all this adjunctive screening. So the enterprise made that consistency a lot easier for us.
Mm-hmm. What is your framework for patient recommendations based on density?
Well, as you can see in this chart, we tried to teach the patients about their breast density with a handout that I made and let them understand what average risk is in terms of their lifetime National Cancer Institute risk, intermediate risk, and high risk, and then stratify them based on density. So if a woman had C or D density, and especially if she had positive family history, we would offer her the Cenobrite, which is the contrast enhanced mammography, or the ABUST, automated breast ultrasound. The best thing we thought was that if you had dense breasts and intermediate or average risk, you might want to alternate having Cenobrite 1 year and the digital breast tomosynthesis with ABUS the next year, alternate years like that. If somebody's high risk, regardless of their density, they need to be having the breast MR besides their mammogram. And some ladies can't have breast MR for various reasons. So the contrast enhanced mammogram is a perfect substitute for that.
And you chose an automated breast density that analyzes density volumetrically. What was your rationale behind that?
Well, volumetrically makes the most sense. Even though the mammogram is 2D, the breast, of course, is 3D. So I want to know the 3D volume. And I think that doing it in that manner is much more accurate. By doing that, we realized better what the density was in our population. So it really turned out that there were some analyses just using your eyes as a radiologist that you would think might be a B like boy instead of a C, or vice versa, and you just got a more accurate, more consistent evaluation that way. So I was very pleased with that.
And after you moved to this density-based screening protocol, what change did you see in your cancer detection rates?
Well, our cancer detection rates went from being 3 or 4 per thousand to 4.8 or 5 per thousand. And that's at a time that the national score that I saw from the National Mammo Data Reporting Base was about 4 per thousand. So we were really doing much better. And I think that all had to do with a combination of consistent evaluation of the density and consistent recommendations for the contrast enhanced mammography. We use the contrast enhanced mammography, the Cenobrite, for those ladies, and we were also using it for post-lumpectomy patients because the oncologists really liked that. It lets you see through the scar and find any recurrence. It's just been the greatest. The Cenobrite finds 10 to 13 additional breast cancers per 1,000 patients compared to 2D, and that's really quite similar to breast MRI, but you can't do breast MRI on everybody because of the time and the cost. The breast MRI will find maybe 12 to 14 per 1,000. So you can see that Cenobrite is quite comparable, and in some ways it's better because it's cheaper and it has fewer false positives. So it's very well accepted by the patients in my area and the referring doctors.
Nice. Well, you recently expanded your personalized approach to include genetic testing. I know it's early days, but I'd appreciate you sharing your experiences so far.
Of course.
Great. All right, so why did you want to tackle hereditary risk?
Well, I think it was really the next step in personalizing breast cancer detection. And as I said before, the whole idea is to find as many breast cancers as you can. So this was the next step. Every decision about adding something new, we really have to try to do what is going to be of clinical benefit. And I knew that risk assessment would add to our portfolio and be even more comprehensive for both the patients and the referring doctors.
What would the addition of genetic testing mean for your patients?
Well, for the patients, I think that would give them a lot of peace of mind. Many of them are often fearful about breast density, breast cancer diagnosis, and they're not sure what it means if somebody in their family has had breast cancer, how old they were, how many people have had breast cancer. So this was really very helpful for them. We found that we wanted to have a system that was going to be efficient and cost effective and didn't interfere with workflow. Every time before that I looked at some cancer risk assessment with genetics, nothing would fulfill those criteria, but Ambry was able to. From a business and marketing point of view, no other practice in my area does risk assessment in this way. So I was able to add finding the Tyrer-Cuzick score and screening for persons that needed to have hereditary cancer risk assessment and find increased risk that would lead to earlier breast cancer detection, and in some cases, tailored approaches that could avoid the patient getting breast cancer in the beginning. For example, some women who have the BRCA gene decide that they're going to have prophylactic mastectomy. The most famous example of that is Angelina Jolie. Or some women will take certain medications like Evista to decrease their risk when they have the hereditary increased risk. So I found that incorporating the Ambry system into our workflow was really pretty seamless and easy.
Excellent. I'm sure that's a question that most people on this call had in their minds when they attended. What challenges do you see in getting started with genetics?
Well, every time you start something new, there's a lot to learn. What this does is to help identify the patients easily, give them the education they need, incorporate the testing via blood or saliva collection, results delivery, and all the counseling and documentation in a way that's easy. The main thing we needed to do was find a way that was going to give the proper education necessary to the radiologists that read the mammograms and have to do with these patients, the referring doctors, our techs, etc. Because we have different centers, everybody has a little bit different workflow and a different set of employees, so we needed to be able to customize things, and we had to get education and buy-in from the radiologists, the techs, and the imaging center managers.
Mm-hmm. And how did Ambry help you with that?
Well, Ambry's program is called CARE, and that's an acronym for Comprehensive Assessment of Risk and Education. So they're going to do the risk and they're going to educate, but they also helped me with the education. I had to make sure that everybody on my side was comfortable with what was going to go on and why. So they had a lot of one-on-one education, and they had these kind of genetic 101 meetings that they would have after work for the techs and the front desk registration personnel to teach them what this was all about. Many of those persons don't know anything about genetics and hereditary risk, so that was very important and engendered a great deal of enthusiasm from my staff. They also helped me with developing a slide deck and information that I could share with the radiologists so that they would also know what they needed to know. Then lastly, there was a lot that needed to be done in terms of customizing a letter to send to the referring doctors to get them prepared for the information that was going to take place. I needed to change my mammography report template to incorporate the Tyrer-Cuzick score and information about any genetic testing if it took place, and they helped me with all of that. They were really very available, very helpful. We worked together quite well.
Wow, it sounds all inclusive.
Yeah, they really were. Very, very good.
Would you mind walking us through the patient experience now?
Well, sure. What Ambry does is to find a way from an IT perspective to access the mammography scheduling system. So I have a risk, but if you're at a hospital, it would be the HIS, the scheduler. And they contact a patient who's scheduled for a mammogram 5 days prior to the mammogram. That's how they identify who they're going to contact. That patient is then either via a secure text message or email link connected to a virtual kind of AI-enabled assessment to gather her personal and family history and evaluate her Tyrer-Cuzick score, which gives you your own personalized lifetime risk of breast cancer. But at the same time, it's getting the information necessary to determine if this lady meets the criteria for genetic testing. The criteria they use are from the NCCN, the National Comprehensive Cancer Network in the United States. And so if she meets the criteria for genetic testing, they tell her right then when they're going through this, gee, you meet the criteria, and explain what the usefulness would be of genetic testing, educating the lady right then and there about what she would need to know. If she decides to proceed with genetic testing, then they tell her what's going to happen next and get involved. Let's say the lady meets the criteria and decides to have the genetic testing. Well, then when she shows up for her mammogram 5 days later, she has her mammogram, and she also has her blood drawn, which we then send to Ambry for the genetic testing. We decided to use blood because my imaging centers have a phlebotomist that starts the IVs for CT and MR, but some breast imaging places might not have that capability, and so you can gather saliva instead. Once the sample is sent off, then the results come back within 2 to 3 weeks. Often it's shorter than that, but that's a safe thing to say, 2 to 3 weeks. For every patient that has genetic testing, they're offered genetic counseling from Ambry. So again, that's not something I have to worry about. They use the NCCN guidelines to help recommend what needs to be done next. The report that goes both to the patient in lay terms and the one that goes to the referring physician is extremely comprehensive and easy to understand. The lead oncologist in the big group in my area said it was one of the best reports he'd ever seen. He was very enthusiastic about it. So that gets taken care of. All of this is documented in the patient's medical record. There's a patient portal so that the patient can always access all this information. And there's a referring physician portal so that she or he can access all the information. And it is all pretty seamless, and it makes it easy. I'm not a geneticist. I don't know all the detail about this, but Ambry does, and they made it easy for me to provide this solution for the patients and the referring doctors.
Beautiful. Can you give us an example of a patient who meets criteria for high-risk genetic testing?
Well, sure. A lot of times it's somebody who has some red flags that you might think of. So like in this patient example, she has multiple family members that have had breast cancer. So if you have 3 or more relatives on one side of the family that have the same kind or related cancers like breast or ovarian in women or prostate and colon in men, that's kind of a red flag. Another thing is if there are family members that have had breast cancer at 50 or younger, and then there are certain particular cancers that kind of run in families like male breast, multiple female breast, ovarian, prostate, and so those are things that might be a risk. In this example, there's a lady who comes and if she hadn't gotten the genetic testing, she might not have known that she has this increased risk. But by going through the program, she found out that her Tyrer-Cuzick score was elevated. She was flagged as high risk, had the genetic testing, found out that she had the BRCA gene, and that way she could know right away and besides getting her annual mammogram, she could get the annual MRI. She could also consider whether she wanted to have prophylactic mastectomy. And more importantly, it's not just for the patient, but it's for her family members. You know, she could tell if she had sisters that she had this. She could let her mother know. A woman who's older than 41 might have daughters that need to be considered in this. So that's very important too. Having an automated process like this makes sure that you're going to capture all the information that you need to identify women that are at increased risk and help them to get consistent evaluation and give them unbiased and guideline best practice documented recommendations for what to do next.
It can be life-changing, clearly.
It sure can.
For the whole family.
Yeah.
So you got started in September with Ambry. What have you learned from the launch?
Well, I think one of the things you have to do is to pay attention to education and assessing what you're doing, take a measured approach, work out the details. We have 6 different locations and all these different employees. So we have rolled this out one location at a time. We just started with our 4th location a couple weeks ago, and we're hoping that by the end of January, all 6 locations will be involved. Right now, we've had many patients, almost 3,000, that have gone through this process, and then about 600 have met the criteria to have the genetic testing, and over 200 have had the test ordered. With a little bit less than that, the test was completed. So by and large, the reception to this has been very positive. We're getting all the results that you would expect for the averages. The only thing that's different is that the number of patients that have a Tyrer-Cuzick score greater than 20 is 4.5%, and the average is higher than that. I think that's a combination of 2 things. First of all, we have a small sample right now, only about 2,000 patients. But the other thing is that because the Tyrer-Cuzick score is for the lifetime risk of breast cancer, as a person is older, then their lifetime risk, which is now a shorter lifetime, goes down. So for patients who are 70 and 80, then their Tyrer-Cuzick score is lower just based on their age. And I think that accounts for some of that.
Mm-hmm. Makes sense.
Yeah.
What insights have the test results shown you about your local population?
Well, including all our sites, we've had about 6% positive so far. And you can see in this chart on the right what different gene mutations have been identified and what cancers go along with them. One of the things that's very nice is the VUS, that's the variations of your genetic code of unknown significance, is much lower with Ambry than with the industry average because of the way they do things. And having a VUS is sometimes disconcerting and upsetting for a patient because they don't know what to do about it. Having a lower rate like this, as opposed to 55%, it's only 23%, is excellent. Plus, Ambry tracks that for the lifetime of the patient and always is comparing to new data, so that if something new comes along, then they contact the patient and say, hey, this used to be a VUS, but now we know it's negative, or now we know it's positive, and this is what you have to do. So all of that has been very helpful for the patient feeling comfortable and the referring doctors having confidence in this system.
I think it's very important to see that you're not just finding breast mutations, but there's other cancers as well that affect the whole family.
Absolutely. That's why it's important for the whole family, not just for the woman. So she ends up being kind of the gateway to taking care of her whole family.
Mm-hmm. Well, here's a very important question. What does this testing cost your patients?
Boy, that was something I was really concerned about, and was a reason that I never got involved with any of this prior to Ambry. So far, the majority of patients have no out-of-pocket payment because there are so many insurance companies that Ambry is in network with. If a patient had no insurance whatsoever, then it would be $249, which is very inexpensive compared to what it once was. It used to be thousands of dollars. Any patient where their out of pocket is going to be more than $100, Ambry calls them and they discuss it and figure out ways to either have a payment plan, or if the person has low income, they can qualify for a reduced cost. But even with all that said, the average out of pocket has been less than $40, which is pretty reasonable.
And your patients have been cool with that?
Oh yeah, not a problem.
That's
Not a
great.
problem at all. The cost has not been a deterrent, which is nice.
Yeah. Well, any final comments or advice for others considering to add genetic testing?
Well, I'd like to say that it has been far easier than I ever thought it would be. Patients and referring doctors have been very happy to have this. The radiologists in my group, some of them were skeptical, but Ambry took the time to speak to them one-on-one, and then they became cheerleaders and were very enthusiastic. So as long as you take your time and you see any places that there's something that you could do better or you could correct, and you take the time to educate, it works out very well. I think it's a great end-to-end solution for getting the Tyrer-Cuzick score, which I can add to the MAMA report, finding out who needs genetic testing, getting the answers for those persons that do need genetic testing, and then taking care of them in a comprehensive, consistent manner with the guidelines from the NCCN. It's been a great addition to my personalized breast cancer screening program. I'm very happy, Allison, that you introduced me to Ambry.
I'm so glad that I knew you and that I could make that introduction.
Yeah, it's been great. They have been a great company to work with.
Great. I'm glad to hear it. Well, I want to thank you, Dr. Keller, for speaking with me today. I'm sure the audience can appreciate everything you talked about, the struggle to maintain quality during challenging times, whether that be COVID or just Breast Cancer Awareness Month. You showed us how your techs achieve and maintain good quality positioning and compression with the help of Volpara. And it seems like everyone's talking about how to get started with a high-risk program. You shared your success in using breast density to triage patients to supplemental screening, and the positive effect that alone can have on detection rates. And lastly, your insight into offering genetic testing to your community. While starting a genetics program may seem daunting, it sounds like the Ambry Care program simplified that process, and it's not only helped you identify more women at risk for breast cancer, but other cancers as well.
Yes.
Good. Glad to hear it. So I'm going to hand it over to Erica now for Q&A.
Great. Thank you, Allison and Dr. Keller. And I want to give an extra thank you to Dr. Keller. As you can see on this slide, she has shared her personal contact information and is happy to answer questions privately and directly if you'd like to reach out that way, which is a very generous offer. We will be, as I mentioned, sharing this recording as well as some links to some of the video content that both Lake Medical has used to promote their new genetics program and some of their other quality initiatives with you. But at this time, I'm going to open it up to Q&As from the attendees. You're welcome to add those to the meeting chat, or you can also email them. Again, you're welcome to contact Dr. Keller directly. We do have a question coming in, and we have experts from Ambry that can speak to the Ambry program in the Q&A process. We also have Allison that can talk to Volpara if needed. But I see a question here which came in, which is, does Ambry provide both pre and post-test counseling? So Dr. Keller, you could share your experience, and then we can also let someone from Ambry comment.
Right. They do the pre-test counseling when there's that first contact before the mammogram, and then anyone who goes through the testing process has the opportunity for genetic counseling. Especially if it's positive, they're going to do that. But even if their test is negative, they may have questions, and Ambry is happy to arrange that. And I'll let Ambry personnel tell even more.
Absolutely. Thank you, Dr. Keller. The answer is yes. The good news is we do offer pre and post genetic counseling services to all folks that come through this program.
Great. I have a question here for Dr. Keller around breast density and informing women and really educating women and referring providers about breast composition. What have you used that's really been useful in educating women on their density and really understanding what that means and getting their referring providers to understand as well?
Well, I think that showing the women what the density is, there's that famous 4-on-1 picture where it's a left breast CC mammogram and it has the A, B, C, and D. So I made up a two-sided one-page item that I can hold up here. I made it this so you can see that picture. And I would show them, look, this is a mammogram. A mammogram is black and white. You can see these 4 different ladies, and I orient them, and I let them see that. Why does it matter what density it is after I show them the density is the white part there? I say, well, because cancer is white, and white on white is just hard to see. And then I go through explaining to them that you can miss as many as 1 in 3 cancers in women with dense breasts, and that about 75% of cancers are in women with dense breasts. So that's why density is important. Then once they get the idea about breast density, I can explain to them what does 2D versus DBT do to help with breast density? What are the other kinds of screenings that can help to see more cancers in women with dense breasts, such as the Centibrite contrast enhanced mammo or the ABUS? And when does breast MR come into play for women that have high genetic risk, or women that are recently biopsy positive so you can find extent of disease? And once they understand those things, then it's really simple to them. Everybody can understand that. Then with the referring doctors, I supplied these same information sheets to them so that they can use that to give their patients, and it's a self-explanatory, so they may not have time or expertise or interest in going through that, but it helps to explain. So if the patient says, oh, my mammogram report says I have da 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 da, they don't have to dream up what to do. They can say, oh, here's this. And if they have any questions, they just have the patient contact us, and one of my lead techs will speak to them even more, or I can at their next mammogram appointment.
Great, wonderful. I see a question here specific to the education credits for this webinar. I can happily clarify this. Because this webinar goes in depth about specific vendor solutions, this webinar does not come with educational credits. However, Volpara, and I'm sure Ambry, have educational courses on associated topics. And so we're happy to reach out directly and speak with you about how you can claim those credits. So thank you for that clarifying question. And one additional here, specific to the genetic test. Who actually orders the genetic test?
Yeah, good question. I think every site's going to be a little bit different. I think there's certainly an appetite within Dr. Keller's team to really put the patient front and center, and her team has done an amazing job of assuming being the ordering physician for these tests. We have solutions with third-party organizations that allow us to have a third-party physician order those tests if we have potentially sites or large imaging groups where their RADs just aren't comfortable doing so. So we have various solutions, but within LMI specifically, yeah, it's Dr. Keller's team.
Right. And the other thing is that if a patient isn't comfortable with that, then I can reach out to the physician that ordered the mammogram or the primary care physician and speak with her or him about it. And in general, once they understand the comprehensive nature of the Ambry program, then they don't mind ordering it. The fear that most physicians have about it is that genetic testing is so far out of their expertise, they don't want to be burdened with something that they don't know anything about, and they won't know what to do with the results because they want to do what's right for their patient. Once they find out that it really all gets taken care of for them, then they're happy to help. And I had a conversation with the lead oncologist of the large group in my area because I said, what if a patient has no referring physician and ends up with positive genetic testing? I need to have some oncologist who will help out. And they were more than happy to provide that assistance to me because they want to help take care of the patients. So I arranged for that ahead of time just in case that came up, that a patient wouldn't have any referring doctor. And so far I haven't had any pushback. It's all been well received because it's a smooth process.
Great, thank you. Any additional questions? You're welcome to unmute or type in the chat. Well, I think that's good then. I want to thank everyone for attending today. And if you're in the East Coast, I hope you stay warm in the snow. And Dr. Keller and Allison in Florida, thank you for the discussion. Really appreciate the insight that you shared. Thank you to the Ambry team. And we will be sharing, again, the recording with a survey to get your feedback on this specific session. As I mentioned, we're committed to continuing to bring best practices to you. So looking for feedback and insight from you on what you want to hear next from your peers. So thank you so much for letting us share today.
It's been a pleasure. Thank you.
It's been a wonderful partnership. So thank you, Dr. Keller and Volpara. Oh, here comes all the praises through the chat. This is nice.
This is what we've been waiting for.
Allison, wonderful job. Thanks, everybody. Stay safe. Have a nice day.
Thank you.
Thank you.
Bye-bye.
Bye, everyone.